All right, everybody, we'll go ahead and get started. I'm just going to do the introductions for the next session. So our next session is called Building Consensus, Shaping Canada's Pancreatic Cancer Pathways. We're really lucky to be joined by Dr. Breffney Hannon, Leah Stevenson, and Jamie Moghop. So Dr. Breffney Hannon leads the palliative care program at Princess Margaret Cancer Centre, a clinician investigator originally from Ireland. Her work focuses on early palliative care models for advanced cancer, supporting caregivers and strengthening advanced care planning to improve the experience of patients and families. So really grateful to have you here today, Breffney. Thanks so much. Leah Stevenson is the strategic lead of All Can Canada and a systems change strategist dedicated to improving equitable cancer diagnosis and care. Inspired by her caregiving experience, she has spent almost 20 years advancing equity-focused healthcare, community-governed data rights, and large-scale collaborative initiatives across Canada. So thanks so much for being here today, Leah. Grateful to have you. And Jamie Moghop, she's going to be joining us virtually. She's the health policy and outreach manager at the Gastrointestinal Society, where she gathers patients and caregiver insights to inform policy and improve access to care. With a BA in law, she has spent 8 years representing patient communities through advocacy, medical writing, and work on key national health policy issues. So thank you so much, guys. Oops. Awkward pause while we get the slides going. Thanks, everyone. Really great to be here. And what a fantastic session by Louise and Jim. I really, really enjoyed that. Thank you so much. Now we're going to put you guys to work because you've been listening and sitting and paying attention so intently for the past little while. So I'm just going to briefly give you the background to what we're going to do, and then Leah's going to make us all move and think and progress. So some of you will remember the fantastic conference 2 years ago, where there was consensus that Canada needs a better defined, standardized pathways to diagnose, treat, and manage pancreas cancer. I think we can all get behind that, the spirit of that idea. And so the findings from that conference were published, which was fantastic. And you all have a copy of that publication in your little binder. Following on from that, there were a number of working groups of diverse experts, including surgeons, medical oncologists, primary care physicians, who came together to create an initial proposed number one pathway to PC to me means palliative care. So I will always default to that, to pancreatic cancer diagnosis, as well as treatment and management and pancreatic enzyme replacement. That third one, we're going to park for now. You're going to talk about that tomorrow. And the first two are also in your binder. These are in draft form. So what we're really hoping to do today is get the collective wisdom of this room to review these, really critique them, tell us what the strengths of these documents are, where we can maybe tighten up or make them a little bit stronger. And then define a plan to mobilize. I think, Leah, I'm going to hand it over to you now, right?
Good morning, everybody. Thank you so much. So yes, today, this rest of the time is really us doing some workshopping. So we're going to start out in small groups, and then we'll come back together, and Jamie will help facilitate some debriefing, particularly on that last question around mobilization. In the small groups, we would really hopefully all received these 3 questions in advance, and I know how busy people are, but hopefully you had a little bit of time to take a look at the pathways and think a bit, but we're going to give you a bit more time now if you didn't, or to just supplement what you've already done. So we are asking you to think about 3 key questions today. What are the gaps that you see in the pathways? There's 2 different ones. You may have more opinion on one or the other, or specific expertise of portions of them. By all means, just focus in on where you have that expertise. So what are the gaps that you see in the pathways? What needs to be improved? And be really specific, because Craig's cause would love to be able to finalize, move towards finalization of these pathways through all of your insights today. And then the third question, really important, we have a very complex system in Canada. You just learned about the complex drug approval and listing, pricing and listing process. as you all know, healthcare is provincial and territorial jurisdiction, and the feds have 5 different programs as well. So we have, even in the implementation of healthcare itself, to implement any of these pathways, it's a complex process to get that broad implementation within a jurisdiction and across jurisdictions. So we really want to hear your best thoughts on the opportunities that you see to mobilize these finalized pathways so that we can gradually get that broad adoption and implementation. So the process that we're asking is to gather together. Some of you are already in some larger tables. So there's, I think, 4 tables that have flip charts on them. If you could gather together in groups of 10 or so, if you have to move a chair, please do around those tables that have the flip charts. That would be great. I'll give you a moment to do that in a second. And we have, for those of you who are virtual, I think you might be using a breakout group for this process. Then you're going to be given about 5 minutes, 10 minutes in total. So 5 minutes to take a look at each of the different pathways. And on your own, and you have these in hard copy in your package, so pull them out. You also have this really awesome notepad. So take 5 minutes per pathway and just on your own, write out your answers to these 3 questions. Again, maybe you have more expertise in one pathway or another, that's fine. But just take some time reflecting and writing your responses to these 3 questions. And then we're going to spend 20 minutes in your group where you can one at a time share what you responded to each of the questions and really chat with each other. Okay, where are we finding some consensus? Where are there some themes where we're all identifying the same types of gaps and improvements and opportunities? Or maybe there's some new exciting ideas that are coming out of that conversation. And if one of you could please jot down what's coming out of that group conversation. What are those key themes, those outlier ideas, those really exciting concepts? If people, put circles or stars around things that people are going, oh, yeah, we really think that's important. And at the end of that, then we'll move on to the next piece where we will be asking whoever took the notes to please share back some of those key points related to question number 3 in the full room, and then we'll have a discussion about them so we can really explore, once these are final, how do we get them brought to life fundamentally? Clear as mud, I hope. Good stuff. So let's start out by getting together in groups where there's, as I said, 4 tables with flip charts. So gather as many as you can comfortably fit around those flip chart tables, and just take a minute or so to do that. And for those of you who are virtually, if you're going into a breakout room or whatever that looks like, you can just get yourselves organized. All right. So I'm going to time it out in 5-minute chunks for you. So please take a look at the diagnostic pathway and take 5 minutes. We'll tell you when the 5 minutes is up. And please write your own answers to these 3 questions related to the diagnostic pathway. What are the gaps? What needs improved? What are opportunities to mobilize that final pathway for broad implementation? So just take your time and write your own thoughts for the diagnostic pathway.
Yeah, that should be okay. Yeah. Hi, all. It's just Stephanie here with Craig's Cause in the back. Jamie, are you
Yes.
able to, well, first I'm going to get Jessica to share her screen if she's there. And Jamie, are you able to start that discussion? Maybe start
Sure.
with the pathways to diagnosis?
Okay, I wasn't clear whether we
Oh,
were.
I don't even hear
Oh,
you. Can anyone else?
I can hear you. Can you hear me?
I
Can hear
can
you.
hear you.
Yeah, we can hear
Are
you.
Okay.
you guys hearing each other okay?
We're hearing
Thumbs
each
Yes.
up?
other, yeah.
Thumbs up? Okay, so I'm gonna let you guys take care of that.
Okay. Sounds good then.
Okay. Thanks, everyone. Thanks, Chloe.
Okay, I just wasn't sure if we were being broadcasted. Our breakout room was being broadcasted to the whole
That's why I was
conference. I
keeping
thought,
quiet.
yeah, yeah.
Yeah.
But okay, so this is being shared here. So it's very nice to, I think if everyone in the, if everyone can also share, I mean, I don't think there's that many of us in this breakout room, but would love to see and hear from Rodney, Jill, and Joan here. But my name is Jamie Maagkop. I'm with the Gastrointestinal Society. Oh, okay. All right. Wonderful, Joan. And I believe Dr. Ramji saying you've worked with us in the past. You probably worked with Gail mostly with some of our work on the pamphlets as well. So very nice to put a face to the name. And Chloe, Eva has been
Yeah.
mostly my contact. So
Absolutely. Yeah, yeah, no, but it's lovely to meet you, Jamie.
yes, that's very nice to meet you. I don't know if you've had a chance to look at the pathways.
Yep.
I
Okay.
did not actually. I didn't get anything emailed to me, so I'm
Oh
just
no, no.
Uh,
I mean,
Let me see if I can
yeah,
drop it in the
yeah.
chat. Oh no. Oh, we have admin restrictions.
it's all good. I can I'll review as you guys are going
Yes.
through it.
So I think I mean, really, when I was going through these, it, I took a look at also what's been established out there. And honestly, Dr. Ramji saying your work with the Nova Scotia, establishing the pathways for pancreatic cancer, I think really is a great model for this. And I think they have put this together in more of a patient focused formats. And I think I'd love to hear everyone's thoughts on that so then we can have that
About a minute left on that
perspective.
first diagnostic pathway.
Oh,
If you're already done, feel free to take a look at the treatment and care pathway. That's the next one.
okay. Well, for the first diagnostic one, any thoughts on
I mean,
that?
the problem is they're all like kind of non-specific. They'll show up in a merge. And so what the emerge docs will do is they'll think about what are the most life-threatening that's going to affect the patient in the next 24 hours kind of thing. And then everything else will be done as an outpatient setting. It also depends on what the patient says. If I've had belly pain for 3 weeks and I'm constipated, they're going to go down one pathway versus
Hmm.
I've lost 40 pounds, have back pain, or I show up jaundice. Uh, so it kind of depends. Um, yeah, as Joan said, like if they come in painless jaundice, I think it's a very clear thing that they need imaging, blood work, and then based on that referral.
Okay, so that's 5 minutes for your reflection on the diagnosis pathway.
So
If you could now take a look at the treatment and care pathway and just repeat the process, reflecting to yourself on these 3 questions and writing down your responses to them. And if anyone needs any kind of clarification or assistance, just put your hand up and we'll jump over. So 5 minutes on the treatment and care pathway.
Oh, these are just for reflection. And then we do have more time for discussion. I understand here.
what?
I wonder if you could share the files through Zoom here.
I mean, I think it's okay. I can see it on the screen, so.
Yeah, okay.
So I think there, the big thing is every center, every province might do things a little differently. So in Nova Scotia, our surgeon said we want to be point first contact when it comes to all patients, including the metastatic pancreas. And then they are the ones who send the referrals for biopsies versus GI for stenting or whatnot versus for further imaging versus to medical oncology. Uh, and I actually think that's appropriate because you need to know if they're surgically resectable or not, which will be dependent on then what you're going to give them from a medical oncology or radiation standpoint. But I think every center is going to be a little different depending on where you have. So, like, there are some provinces that don't have HPB surgeons. So, in those situations, you may want to get a medical oncologist involved first to help kind of quarterback everything.
What's the how many do you know how many there are approximately of HCC surgeons or
I mean, so like I think Nova Scotia we have four, PI has zero, New Brunswick has
oh,
one or two, Newfoundland has one, I believe, maybe two,
Sorry, I'm
as
actually
well.
from Newfoundland. I'm an
Oh,
HPV surgeon. I just started, so we now have three.
oh,
excellent.
yay.
Great to go.
And I think every province in Canada, maybe except for PEI, does have HPV subspecialty available.
Okay.
And for most provinces now, it's multiple sites.
Okay.
So, hi, sorry, I'm a med student at McGill. Just to clarify, Dr. Vallis and Dr. Ramji Singh, these are the number of centers that have HPB surgeons, or the total number of HPB surgeons per province
The ones I listed were the number in the province
of institutes or surgeons.
surgeons.
Okay, thank you.
So I know like Ontario, Quebec have a lot more when it comes to HPV surgery.
And so do those who live in PI then get referred to some of the Atlantic provinces?
They get referred to Halifax
Oh, okay.
most of the time. I think some of them may be going to New Brunswick now.
Mm.
Yeah, the New Brunswick HPV program would be newer than Halifax, but I think they have two HPV surgeons there now, so they're developing more, expanding their practice.
About one more minute left as you just wrap up your thinking on the second pathway. And then we'll move into small group discussions. Hey, I think most of you look like you have wrapped up. So now we're going to move into small group discussions. So using what you've already written down, if one of you wouldn't mind acting as sort of the table note taker and jotting down what people are sharing on the flip charts, and also just helping facilitate to make sure that people are going around one at a time. You've got about 20 minutes, maybe about 7 minutes per question, roughly. Start with question number one. What are the gaps that you see in these two pathways? And then move to question, go around, share what you're thinking, what needs improved, repeat, and then end, of course, make sure you have time for the final question. How do we mobilize? So let's take about 20 minutes, one at a time, sharing your responses to these three questions. And if one of you could kindly please take notes on that flip chart so we don't lose any of your valuable insights. Thank you.
Now, let me see if I can share my screen. Hopefully that doesn't disrupt anything on their end here. but I'm happy to take notes since I'll be the one reporting back anyways. Let me find it here. Can everyone see this?
Yep.
Okay. Any thoughts on the symptom assessment here? We're looking for gaps, strengths, and areas for refinement. And I think I know Dr. MG Singh mentioned about triaging from usually focusing on the most urgent here.
Just a general comment. Is this assuming that the first person that sees the patient is in the ER or a family physician? Because as Dr. Ramji Singh said, it might kind of change the urgency or what's prioritized for the patient and where they get then directed to.
No, it's not specified, but I think that is important to then mention that it will
Yeah.
be different, right? If it's
Mhm.
with a primary care physician, or if it's a walk-in clinic, because not many have access to a family doctor, that
Right.
will change things.
Right.
I will also say, like, I just had a patient present to their pharmacist
Oh,
who
Wow.
actually was going in for vaccination, was actually seen to be jaundice. So
Wow.
I think we got to think broadly
mm-hmm.
as well.
So should
Okay.
we be saying that we should try and find a more standardized entry point for primary care when it comes to this?
Well, I think if they also appear at the pharmacy, I think there would be some need for education for their area as well, right? So with did they refer them, Dr. MG Singh, or?
They sent it to emerge.
Oh, okay.
Yeah.
I think globally, something that's missing from these drafted pathways is defining whose responsibility is what. Like every step in this pathway doesn't really say, like, for example, it might say everybody should be referred for or prescribed PERT, but like whose responsibility is it to prescribe that? Same as all of the referrals. Are they all on the primary care physician? Are some of them the responsibility of the med onc? And there might be more clarity on that within the system already than what I'm seeing written on these documents, but it's something that I know is missing in terms of what we're specifically stating.
I will say one of the problems trying to create pathways is the entry points, as in who sees the patient first, who takes ownership of things. When we were developing our Nova Scotia ones, I think we spent a year and a half going through conversations and meetings to
Hmm.
try to kind of figure things out. And it's even more complicated than it was back in 2017 when we started this.
And do you think every province would approach that discussion differently?
Yeah, because
Mm.
the resources available to you. As well. So I don't know if you're going to be able to have one pathway that's going to be matched for every single province, because provinces have different access, different resourcing, and patients are going to present differently. They may have a family doctor. They don't have a family doctor. They have a nurse practitioner. They may not have a nurse practitioner. They may just show up to a Emerge or a walk-in clinic. They may show up in a pharmacy. And so the pathway, I think, would be more like if a patient presents with these symptoms, this is the next theoretical step that you should be thinking about, kind of thing, as opposed to um, direct A to B to C to D, because it depends on everyone's A is going to be different.
Dr. MG Singh, would you be able to help us, maybe not on the spot right here, but help us come up with as comprehensive of a list of that A point as you can?
Yep.
No?
Yeah.
Yeah. Okay.
Yeah. Yeah. I
If
mean,
you're still on
we're
question 1, you might want to wrap it up and start moving towards question 2.
fair enough.
Okay. So I'll just quickly slide through the rest of these. So, I mean, we've basically discussed the assessment and some of these physical exam, figuring out really, like Dr. Abdising mentioned, that entry point. And so what I'm hearing, and correct me if I'm wrong, do you think there's some sort of a level of responsibility for several healthcare professionals and even for patients and caregivers to be, well, mostly the healthcare system on knowing some of these the main points here of the symptoms, and then knowing when to refer
Yeah.
them.
I mean, so we had done years ago family physician outreach to kind of remind people, because the problem with the family physician is they may only see one of these a year. And so it's not going to be like on the top of their mind kind of thing. Um, and so you need to kind of just say, hey, if they have these symptoms or even one of these symptoms, you still got to think that in the back of your head that this could be it.
Chloe, any thoughts on, especially from a Quebec perspective as well?
Sorry, I missed that last part.
Oh,
Oh, yeah, go ahead.
sorry. What I was saying is like we've done this before with the family doctors, trying to
Mhm.
uh, remind them that whatever symptoms people have, because the problem is family docs may only see one or two pancreatic patients in a year or in a couple of years. So the symptoms aren't necessarily going to pop out to them that, hey, I have to think about pancreatic cancer.
Yeah.
And so I think there has to be constant reminders of think pancreatic cancer, even with one of these symptoms.
Yeah, I mean, we definitely agree. In Quebec, it's really weird because there's like no clear pathway that's kind of started, and we're trying to push to kind of put a more like value-based healthcare lens on things. So really coming out with what patients are experiencing and try and like get that connected with physicians and how they approach patients. But I don't know if there's like a like a be all end all rule about how physicians should be like looking at certain symptoms and thinking pancreatic cancer.
Yeah.
Also, I heard Dr. Anderson, you mentioned, so you started this work in establishing the pathway in 2017. So it's
Yeah.
taken years, clearly. So
It
to
took
really,
years. And then we're just about to revamp. We're going to look at revamping it in the next week or two. So it's going to take more years to revamp as well, because once it finally got published, it was out of date.
mm, yes. And so I think that that's something that's actionable is, we need more than just a session here to really take a look at these pathways. This is going to take, if we're going to include multi-stakeholders, this is going to take a much longer time to really look at it and refine it because we haven't even gotten to the blood work and imaging yet. So for folks here seeing
So
this
we're
for the
at
first
the
time.
10-minute mark.
Oh,
Wrap up on the question you're at. If you don't have time for what needs improved, that's okay. Move right to the third question. How should we mobilize the final pathways for broad implementation? We really want to hear your thoughts on how do we actually bring these to life and action.
Okay.
Number three is a lot easier to deal with.
Yeah.
You have to publish something, and then that allows the team, surgeons, med oncs to go back to their local institutions to say, here's a published pathway of theoretically what should be done and how can we mobilize or resource it so that we can do something similarly and modify it for our institution depending on what we have available. But really, it's create some documentation that can be published so that people can have access to it to go back to it.
That's exactly what I was thinking because you've done the work already, and I believe too there's pathways established in
Alberta has a pathway,
yes, and
uh,
Saskatchewan too.
Saskatchewan too. So there are provinces that have pathways. And I think the pathways are relatively similar. There's little nuances that are a little
Mm.
different just based on the resourcing as well, but they're more or less similar. And so I think you create a national document that gets published in a peer-reviewed journal that then you can take back to your institution and say, hey, this is what is being suggested. How do we do this? Because, for example, yeah, at one point we only had one physician who does EUS biopsies 1/2 day a week. So
Wow.
if the recommendation is all patients need to have a US biopsy, well, that's not going to happen uh, when you have such limited resources. So we have to resource it. So, like, depending on what's being published, that is what's going to allow you to go back and say, hey, this is what we should be doing. Can we get a resource to do this?
I think also we need to like still make sure that we're aligning with like the provincial systems because like not every province has the same like to the point that you were making, Dr. Ramanjit saying that like some of there's not a lot of physicians in this particular realm like in the East Coast and like imaging capacity we're talking about like oncology workforce like all of those things like we it still needs to be able to like respond to those like regional specificities.
Yes, yes. And I think because what we're doing right now in for us at the GI Society for IBD, inflammatory bowel disease, we're actually trying to change the standard of care. So what we've done is we've taken the example from Quebec where they've eliminated the step-up process, and we're going to each province actually. We're scheduling meetings with the drug program managers in each province to really to share this work from Quebec and then get down to the work with them and trying to figure this out. So I think this is something that Craig's Cause can do and others who want to support them in this, especially they will need support from the specialists too to really show the need and I'm wondering too, Dr. Armstrong, is there data being collected too to show any outcomes of this pathway for the healthcare system? Because I find that that might also help.
Yeah, I mean, so the problem with the data is they're always years out of date.
Mm,
So if you look at like a cancer program, they're usually working on 2020, 2021 data.
mm,
So you're already 4 to 5 years out of date from what's being implemented now, kind of thing. So, like, I mean, we collect data. I assume other provinces collect data too, as to what the metrics they're looking at is probably different in every institution
Mhm.
as well. But I mean, like, we figure it out things like it took 9 weeks to get a portacath inserted once you've decided you want to start chemo back in 2016. Well, in metastatic pancreas, that means they're dead. So it's probably why we had horrible outcomes. So we fixed it. But every place is probably collecting things a little differently. You're probably
yeah.
collecting it institutionally, not necessarily provincially, except for the small provinces, which an institution probably is the whole province for more or less. But if you're talking about national, there is no national.
Mm, mm. That's also, I think, a missing point, even just for understanding population level with prevalence and
Yeah, I mean, we've tried doing national projects. It just becomes problematic with data transfer across
mm,
provincial lines. There's a lot of contract sharing, and that ends up being time to get those contracts together with the provinces to allow it, and the resources as well to store the information and how you do it. There was a project years ago through Alberta that was collecting pancreatic cancer information. Winston Chung was actually running it before he started running the O2 program in Alberta. But I think
So
that
you've
kind
got
of
a little over 4 minutes left. If you can be spending some more time on the mobilization piece, it's very difficult to implement in our fragmented system. Would love to hear your insights on this piece.
Of course, it's Dr. Chung. I've seen many of his presentations on real world data collection as well. So it's great that he's leading. He's also worked on that as well. Any other thoughts from others in our virtual room? I don't know if they've caught up.
I think just talking about how we roll things out of primary care, there's kind of 2 points that kind of come to mind for me. One is to make it as simple as possible. So I think once you start talking about getting into MRI and EUS, that should really be a subspecialty decision and not something that's put on the primary care. And I know in a lot of provinces, primary care physicians and nurse practitioners are really limited in what they can order from an MRI perspective. So that could result in like months and months delayed for a patient not being diagnosed. So I think once you have any question on a CT, that should then prompt in a central intake. And I think encouraging provinces to create their own central intake is really important for like early triaging of these patients. And then the other thing to think about is that primary care more and more is being taken over by nurse practitioners. So I think we have to think about how we distribute that across Canada to our nurse practitioner population, because there might be a limit between what papers that family physicians would have access to, but not necessarily nurse practitioners.
I think too, going back to what Dr. Ramji Singh was saying about the, low incidence of the disease, like how do we get a primary care physician to even think that they need to open up their pancreatic cancer pathway? Like, what is the pathway when a patient shows up and says, my stomach hurts? And where do we fall into that, like, to-do list? Or do you know what I mean? Like, what can be the red flags and who do we need to communicate this to in order to say, like, you need to be thinking pancreas cancer?
I mean, I think the big thing is the history. There are some who do amazing history, and from that history will give you a good indication that there's something cancerous going on. Whereas there are some that'll say, "Oh, you're having abdominal pain. This is probably constipation.
Right.
Let's just start you on a anti-constipation regimen or something like that." So,
Do you mean
I
just the individual's history or a family history as well?
individual
Okay.
history. Yeah.
But maybe we should be like talking about the family history too, right? I mean, adding that into what the physician is looking at.
Well, in our patient perspective session last night, I was kind of surprised to hear I presented like some very preliminary data about how family history seems to be factored into um, the urgency and the delay times between diagnosis and or I guess presenting with symptoms and receiving a diagnosis. And many of the healthcare providers chimed in and said familial pancreas cancer is so uncommon that like family history shouldn't be a factor. But I know for myself, like my dad passed of this and his brother passed of this. So I hope that if I ever showed up and
Just
said
take a
like,
moment to wrap up.
this is a factor, that they would hear that. I don't know.
Yeah, I agree with what's just been said. I think also I'm biased because I work with Dr. Zagopoulos, so like a big part of his registry is doing family history
Mhm.
and taking. And like a small anecdote, I was in a vascular surgery clinic, and obviously because I
So
think
we'll
of
give you a
this
couple extra minutes just to wrap up. And if really spend your time on this last question, because it's the one we're going to discuss together as a large group. We're going to
because
ask you
I
to report back on some of your key ideas related to mobilization of the final pathways.
because I think of this a little
Take a
bit
couple last
more.
minutes.
There was a patient where I just asked, because he started talking about like a history. And I asked, is there any history of cancer in the family? And he said, yeah, my dad passed away from pancreas cancer. My mom passed away from pancreas cancer. And he said, I think my sister has pancreas cancer. And so I do think that obviously taking a good family history, as Dr. Ramji Singh and as Jessica just said, is important.
Okay. Okay, I think I've got quite a good amount of notes here and captured your thoughts. No, I was actually very surprised at that too, Jessica, with the findings. I tuned in last night on the survey, and I know it's still you're still trying to collect more responses, and we'll share it to try to get more. But that is very interesting. That the family history was not that, and that they had the same, I believe, waited longer at the same time than those without family history for diagnostics, right? That was the finding. Yes, yes.
Yeah, I
Okay.
think the issue is if you wait, like if you're going to get your radar up because of just the family history alone when it comes to pancreatic cancer, you're going to miss the vast majority of pancreatic cancers. I think a lot of family physicians, if you get the family history, know there's a family history of pancreatic cancer, then they're going to be obviously very concerned. But the problem is missing the patients
You
that
guys
don't
want a
have the
little
family
bit more
history, which is
time,
most of
or
them.
are you ready to report back? Put your hand up if you'd like a bit more time. Okay, so I'd like to invite Jamie from, hopefully she's with us virtually.
Can you hear me? Hello?
Hopefully Jamie can
Hello?
join us and help. There you
Oh,
are. Hi,
there I
Jamie.
am. Okay, hello.
Hi,
Can you
Jamie.
hear
Do you
me?
want to quickly introduce yourself and help facilitate us with the the last section? Thanks.
Yes. Hi,
And feel free
everyone.
to, sorry, just start with the virtual group if you'd like. Yeah.
Okay. Well, hi, everyone. Sorry I can't be there in person, but I'm here virtually. My name is Jamie Magcop. I'm the Health Policy Outreach Manager at the Gastrointestinal Society. So I had the pleasure of leading our virtual room, and we had a lot to discuss, and I'm sure many of you as well, those in person, had a lot to share as well. I wish I could see you all. Um, so with the starting off with the first question, I believe was what are the if I could have the slide on that up. Don't know if that's possible.
And Jamie,
Yes.
if we don't have time, if you just want to touch on the third question, we'll
Oh,
spend
yeah.
time there for a second. The mobilized question. Apparently, I can't bring up the slides while you're up. So
Okay. All right.
we will take all the notes from gaps and improvements and bring Craig's cause will do their best to really implement what you guys are sharing. But I think since we have limited time, let's really spend the time on the implementation piece. Thanks.
Okay. Oh, thanks, Chloe, putting the chat here. So our for the third question, what we've really drilled down to is we have pathways that have been established that had done great work as well already in several provinces. So Nova Scotia with Dr. Ramji Singh as well, a leading that. And we have him in the virtual room with us, so we were very privileged here, and also in Alberta and Saskatchewan. And so we have these models already, and well, it's a great work that we can take on to other provinces to share, and then. As every province and territory are different, have their own little nuances in their healthcare systems, I think this is a great opportunity for Craig's Cause and other patient organizations and advocates and to take on that and go to each province really to show them, okay, this is what's been done. How can we do this in this province? And so that's one of the action items that we've discussed. And we also had a lot of discussion on data collection, and there are a lot of challenges, but I think we need to collect data. And I saw on the agenda Louise was in the previous panel, and so I hope I can't see her, but I hope she's uh, also mentioned that, and I'm sure because she's been championing data collection for many years, and so I think we need to do better in that area, even though there are challenges. because we need to know, and that's how we can also understand really the nuances and where the gaps are. And I believe there were also a lot of discussions on, identifying the entry points for and responsibility for all healthcare professionals, even from walk-in clinics to pharmacists to nurse practitioners, to be familiar with some of these, even at least just with presenting symptoms, so then they are able to better support patients who who appear with these concerns and can be better introduced into the for care. And I think I don't know how I'm doing for time here, so I'm trying to go through these notes quickly. So again, we just want to one of the interesting points of data that preliminary data that came about from the patient survey that was released last night showed that not as many patients are being asked about their family history of cancer. And so I think there also needs to be more work on that, and even just on perhaps educational materials and more awareness piece as well, to encourage more of those conversations, because it's very interesting that that's not being asked, and that could be a quick indicator for healthcare professionals to then understand, okay, there might be something here more to understand and for further testing. So that's what we've discussed, but I'm very curious on what the room, what ideas have come up in the room.
Testing. Great. Thank you so much, Jamie. So let's hear from the room. I'm just randomly pick who would like to report back from this table. Steven.
Everybody's looking at me. Okay. So I guess with regards to implementation, I think, well, we spent what 90% of the time on the first pathway, but we did talk about treatment too. I mean, we had sort of generally agreed that kind of putting a consensus statement together, be it a white paper or otherwise, would be an important goal, but then that only goes so far on the implementation piece. That white paper then has to be seen by somebody that actually has then the authority to make change. So, I think the diagnostic pathway and the treatment pathway have different audiences. Okay, so the diagnostic pathway needs to be, we need to focus on early detection, patients that have symptoms. Who is seeing these patients? It's not medical oncologists and surgeons seeing them immediately. So targeting them with that diagnostic pathway is not correct. You should be targeting family physicians, emergency physicians, the general public. And so how that gets done is different than the treatment pathway. But still having the desired state in a piece of paper that is generally agreed on, I think is the right way to go. So we thought with from the diagnosis standpoint, I think an agency, because I appreciate Jamie's comments about the fact that there are jurisdictions that are already ahead and doing this very well. But there are opportunities for national standards, and there are agents like Canadian Association of Provincial Cancer Agencies, for example. It's a collective of all of heads of all the provincial cancer agencies. Going there and then having that disseminated across all the provinces to at least come to some minimal standards, rather than each province, even each jurisdiction within a province, reinventing the wheel over and over again. That's, I think that's, we could probably do it in a more streamlined fashion. For the treatment pathway in terms of implementation, I think that there are groups that, I mean, this group could be enough, but we do have, conferences like EC5, Eastern Canada Consensus Conference in GI cancers. Western Canada has something similar. So endorsement by those groups could go a long way in kind of moving that forward. But again, I think that the start point should be this, a consensus document, which I think we're moving towards. But that's the start of the implementation piece. So I think that we have to think about if we want to take this on a national level, identifying those groups that can speak on a national scale. So for going back to diagnostics, had mentioned that, so if you're trying to target family physicians, you should be talking to the like the College of Family Physicians, right? Because otherwise the message isn't going to get. Am I being cut off with the things? Okay. I'd like to.
No, you did a great job. That's people entering online. So, okay. Thank you so much. That was very thorough. So, anything new that hasn't been shared by one of the two presenters that you guys discussed in terms of opportunities for implementation?
Yeah, so we kind of discussed the same problems you did. And I think the common theme here was who organizes the dovetailing of the diagnostic pathway into the treatment pathway. And the feeling was that there should be one central person, and we have it at our center. That's Nancy here, patient navigator. And we felt that that helps the patients and that helps all the teams be on one page in case patients miss appointments, they're in the emergency, or for some reason, especially with our center, if it's snowing and they don't or cannot come in. So, and that the patient navigators should be clinical staff. So the referrals can be triaged accordingly. So
thank you for that addition. That is actually a really important piece. As we all know, it's those transitions where things really get extra messy. Okay. Jim, are you going to share? Awesome. You can read your own handwriting?
So yeah, maybe the table can add anything, but some great points by the other groups. One piece that we talked about was not everyone has a family physician and there's system issues. So from an awareness campaign perspective, who are the targets? And there's lots of different ones. So we also talked about a navigator, but dietitians, nurse practitioners, etc. As I was listening to the group, I just wrote down if there's different pathways, different targets, then there's also different materials for all of those populations. So it might not be the same. So that would have to be considered kind of in an overall change management plan and using implementation science. And really thinking about that, the integration with existing systems. So what can we do to put this out there in something that's already there? So it's not new, but an add-on. And then the one thing we briefly chatted about was, is there connections with other pan-Canadian health organizations? So potentially Health Excellence Canada or someone else who could help spread this for you rather than doing it all on your own. Anything from the table?
That's all the tables, Jamie.
Okay, well, I'm hearing lots of great ideas, and really, the point on not everyone has a family doctor, has access to a family doctor. We do need to remember that. I mean, our group here, Dr. Ramji Singh mentioned a patient approached a pharmacist, and so they were then referred. But these are the real life situations. When we do a pathway, we have to consider all the other factors, that it may be a nurse practitioner, it may be a different healthcare professional that patients are approaching, and so they will all be different. And I do understand. I heard the comment on the national standards, and while that's true, I think it really will still end up going down to the provinces, because there are so many differences in how each healthcare system works. And I don't know if Chloe would like to speak on this from the Quebec perspective as well. She mentioned some of the work that they've tried to do from the coalition. Oh, I think she's coming on screen.
Yeah.
Is the room able to see her? Perfect. There you go.
Okay, awesome. Yeah, so unfortunately in Quebec, there isn't a care pathway in pancreatic cancer, but we've been doing a lot of pushing and advocacy to make sure that we can really get this thing going. We did a huge project last year with a bunch of our member organizations, including Craig's Cause, and they created an incredible chapter in our report. So I don't know if you guys have access to it, but I would strongly recommend that you guys take a look at it. And we've been really pushing with the Quebec Cancer Program, which is the one that really gives those recommendations to the government to kind of get those things implemented. And another thing that we've been doing that we think is really important, and I think this kind of speaks to like the globe, like the more like national pathway idea, is leaning on a more like value-based healthcare aspect and really like taking into considerations the outcomes that matter most to patients and how they're experiencing the whole trajectory, like from when they go in with symptoms to when they're getting their treatment and like the time to access that care, etc. So,
Okay. Thanks, Chloe.
Thank you so much.
And if I could just say one more thing, I know we're
Yeah.
coming up on the time. Leah, we need more time to drill down on these pathways. And we definitely, if we want to take action and implement this, we were gonna have to spend a few days in a room, all of us patients, caregivers, doctors, specialists, and researchers, and regulators too, to really figure out how to do this. But this is a start, and I applaud Craig's Cause for getting this going. And so that's that for me.
Thank you so much, Jamie. And yeah, that might be a really good idea for a next step. And I'll put this in recorded so that it gets into the final notes. But because coming out of today, you guys have done some great work and written down your thoughts around. Please do leave your individual thoughts on the table as well as the flip charts so that the staff from Craig's Cause can collect all of your cumulative wisdom. Obviously, it'll all be anonymized, just for the ideas. But maybe an idea could be to incorporate as best as possible the feedback that came out of today to revise those drafts. Maybe there'll be some outstanding questions where further clarification is needed. And maybe there's some way to bring people together again virtually to do another round to really get towards that final consensus on some final documents. There is so much collective wisdom through this platform, this conference, that could be a really efficient way and a productive way of moving towards final documents. And I want to just make one comment too on the question of sort of national and then adapted for the realities at the provincial and territorial levels where implementation happens. I think it's worthwhile to take an and approach. Working with groups like the College of Family Physicians of Canada, the Nurse Practitioners Association of Canada, the CAPCAs, the CPACs, the Health Excellence Canadas of the world, where appropriate for different pathways, to really try and get that buy-in and consensus, and to be able, because then they have all of their own membership, right? So if you're able to get that level of endorsement in a pan-Canadian organization, then you have that much more leverage and strength of consensus and support, as you are then also trying to encourage the different jurisdictions and to also follow these similar types of standards or adapt them and adopt them for the realities of their jurisdiction. So I think "and" is a good idea when you're trying to work across the complex Canadian landscape. Could we bring up the slides one more time? Just want to make sure we don't miss anything. Thank you. So, no, that was it. So I want to thank all of you. I hope you found this a productive workshop experience. And I really want to thank you for sharing your insights, your expertise. And I know that Craig's Cause is going to make great work out of what you guys shared today. Stephanie, I don't know if you have any last remarks that you would like to share.
So I'd like to thank Leah, Breffney, and Jamie. And I know we also was happy to see that Chloe was also able to attend. This is just an initial step. We know that there's a lot more work, but these came as a recommendation from the last conference. So There was several people from across Canada working on these, and they'll continue. We'll take your feedback, improve upon them, and I think an important step is starting those partners to getting on board as well. But I'm hoping that by 2027 that we'll have a more completed and accepted pathways. It's hard to navigate between provinces, but our goal is that we create one pathways that all specialists and where patients first present have access to. And even though some of the referral process may be difficult and face challenges because it's overburdened, I also feel that we don't not use those referral processes because we need the data to show who we're not servicing. Even, like those referrals need to be made so that we can show that if 10 people were referred here and they weren't able to be seen, we need to be able to show that data.